Hello everybody. Today is Thursday, 2 p.m. and today's session live number 2 with Dr. Gohar from the medical director of Viva Eve. Last Thursday I thought was very good, live Instagram, because Dr. Gohar really gave us a lot of information about fibroids, about the type of fibroids, what all the stuff that they cause, and went to see a fertility doctor. So it was really a good session. We still have 2 more sessions. Today we're going to talk about fibroids and your health. So we're just waiting on Dr. Gohar to join us shortly, and then we can start the session. And I'm doing these. I think he is here. Dr. Gohar.
Dr. Merhi.
How are you, sir?
I'm very good. How are you?
I love the scenery behind you. One day you have a beautiful screen. One day you have a tree. I have walls behind me all the time.
Well, thank you. I had to improvise, Dr. Merhi. This whole Instagram thing is a little innovative.
Instagram is outdated now. There is TikTok now. What is wrong with you? You're still a young man.
Am I falling behind, Dr. Merhi?
You are very behind, my friend. You're very, very behind. It's okay. Listen, after the session next month, we're going to have TikTok sessions every Thursday at 6 p.m. We're going to dance.
Sounds good. I'm in.
So thank you so much for your time. So I was just saying that last week's session was the first session 1 from fibroids and introduction. Today we're going to talk about fibroids and your health. And next Thursday we have another session and final session. Sorry, you have to see me one more time. You have to. I'm so sorry.
Thank you, Dr. Merhi. I'm looking forward to it. It'll be a lot of fun. And I really appreciate you having me.
Thank you. Thank you. So for those who missed it last time, I would like a little bit small, brief introduction. Tell us again, please, your name, and tell us, where you work and what is Viva Eve, because I like the name. A lot of people like the name. And what do you guys do, and why people should go to you, not to someone else?
Thank you, Dr. Merhi. Yeah, so my name is Dr. James Gohar. I'm the co-founder and CEO of Viva Eve. I'm a practicing OB-GYN. I've been a physician now for about 20 years. I run a group of medical practices. We have 3 locations, Forest Hills, Astoria, and our latest one is our new flagship, our new headquarters in Madison Avenue in Manhattan. We're a team of about 11 physicians, actually soon to be 12, and 4 nurse practitioners. We're a group of about 100 people. And ultimately, we really focus on women's health care. Viva Eve stands for Long Live Women. Ultimately, it really represents, I think, everything that we're about. We ultimately see ourselves as reinventing women's healthcare. There's many different facets to that, but for us, it's very clear in our mind what that entails. Really comes down to patient experience above all else, providing innovative technology in a beautiful setting with really highly rated and very, very focused and dedicated physicians. We build everything around the patient, from A to Z, around their comfort, around their environment, around ultimately educating, empowering, and supporting our patients in whatever path they choose. And of course, our core is OB-GYN. That's what I am. But we have several specialties. We also have diagnostic radiology, interventional radiology, anesthesia. We recently added nutrition. Soon, my marketing team doesn't like me saying this because it's not quite up yet, but plastic surgery will be joining us soon. Dr. Larry Reed, we're very excited about having him join the group, but mainly as it relates to women's healthcare. All we deal with are women, and ultimately, everything we think about is all about that patient experience that typically, I think, often tends to be pretty disjointed and not typically very cohesive, not very integrated. It's that integration and that teamwork around the patient that I think makes us different.
Well, that's really great. So the unique things about Viva Eve is that once a patient comes in, she has a lot of things can be done within the same system, including nutrition, gynecology, radiology, and now plastic surgery. I'm
Exactly.
very right. That's actually very interesting. I'm, very interested in the nutrition part, to be honest with you. But we can talk more about this later on. Um, so
Yeah,
tell
it's
us a
interesting,
little.
by the way. You're right, Dr. Mary. We should talk about that. But nutrition, especially, seems to be one of those areas. It's almost like a gray area in medicine. But I think, any one of us and, any of our colleagues, any doctor worth their salt always says to our patients, right, that you want to sleep well, you want to eat well, you want to take good care of yourself and exercise. These are just basic building blocks to good health, both physical and mental.
Right, absolutely. So tell us briefly, I know we discussed it last time, but briefly tell us about what fibroids are and what kind of symptoms patients have, because we're going to move today about talking about health, not just the gynecology part, but tell us about the GYN part right now, please.
Absolutely. Yeah. I mean, look, fibroids, as well as I do, Dr. Merhi, they really impact women's quality of life. It's a very common issue. They say as many as 30% of women by the age of 35, and as many as 70% of women by the age of 50 will get fibroids. One key thing to understand, though, as big as that number is, and it's even more so for Black women in particular, I think on average the stats show Black women are 3 times more likely than other ethnic groups to get fibroids, which is quite astounding, especially given how common it is in the first place. But I think one of the key things to keep in mind is that not all fibroids need to be treated. So really only about 1/3 of fibroids are symptomatic. And that's really the key factor for us when we decide on when we're going to treat someone or not. And so symptoms really come down to quality of life. Like that's really the big overarching concept. And that can come in many forms. Some women are very unlucky and they have all 5 or 6 symptoms. And some are very fortunate and only have one single symptom. So those symptoms are mainly heavy bleeding, painful cycles, pain with sex, pressure, bloating symptoms, or urinary symptoms where people go to the bathroom very frequently because of pressure symptoms from the fibroids. Those are the most common. And then one common thing I often say to our patients is, look, fibroids are very, very rarely an emergency. The vast, vast majority of the time, these are nuisances that make people's lives miserable. There's something that we take seriously, certainly, but it's not an emergency that someone needs to seek care for immediately. And if they don't, something terrible happens. And so it's really one of those situations where we have the opportunity to diagnose and assess and manage, and then ultimately, help the patient, hopefully make the best decision for them.
That's great. So we're going to talk more about fibroids and fertility in a little bit, but tell us about how, is there any relationship between fibroids and immune system overall for the women? Because I get this question all the time, maybe my immune system is weak and that's why I'm developing fibroids. I did this and my fibroid grew. I took this supplement and my fibroid. There's a lot of unknowns about fibroids, right? I'm not up to date with the research, unfortunately, because I focus more on the fertility. So tell us about what you tell patients about that.
Yeah, it's a very good question, Dr. Mary. I think, look, I think there's this concept we talk about a lot in science, and I know people outside of science don't think in these terms. I think investors talk about this as well, though, which is this idea of causation and correlation. Just because something is correlated and happens at the same time as something else doesn't necessarily mean that A led to B, right? So I think we have a common problem, whatever that common problem is. It's very, it's human nature to try to attribute our actions to that problem. In your world, Dr. Mary, I think a great example of this is miscarriages, right? Miscarriages, we know, are remarkably common, right? Like I think the numbers are what, 30, 40, 50% of all pregnancies don't continue.
Something like that, yeah.
So, maybe you get, knocked, like, hey, you did the IVF and the IVF didn't work. Well, in general, with natural conception, if you've got a 30 or 40, 50% chance of a miscarriage, the natural conversation we'll often get, natural conversation I'll have with my patients will be like, what did I do wrong? Well, I had sex, for example, last week, or I went to, my friend's house and I was a little bit more active than I expected to be, or I worked too much. And so it's very common for us as humans to look for reasons and answers and then attribute cause to that. Right. Whether or not those two things are really connected or not is really unclear. So in terms of fibroids, just going back to your question, I don't think we really know, based on any of the research that I've read, whether or not there's any real link between someone's immune system, what they eat, what they do, what activities they have, and them actually developing fibroids. I think fibroids, are unfortunately something we really don't quite understand where they come from. We know that they're very common. We know they're more common in certain ethnic groups. We believe there's a genetic component, but we've never actually isolated the gene. Right. One day, hopefully we will, and that will, I would imagine, make a tremendous difference in terms of how we manage. But I think it's one of the biggest sources of stress I find, and this is, I think, a known concept in psychology, is when we try to change things that we don't control.
Right.
When we try to affect things that we don't necessarily have control over, it really can drive you nuts.
Right.
And I think that's one of the things I see often with patients when they have this. It's just there's a natural tendency to try to attribute things that really are really hard to make change to.
I have to tell you though, Dr. Gohar, I have a lot of patients who have fibroids, and I see it. And I know there's no big studies about it, but they tell me they go for 3 months, they change diet, exercise, and all that, something I should be doing. But and they feel the fibroids smaller, and their symptoms get better. And I see it on ultrasound when I measure the fibroid. I'm like, what the heck did you just do? So yeah. I don't care what people say. Diet does affect our fibroids, whether positively or negatively. I don't know if it's gluten, which is a pro-inflammatory thing, makes it worse or not. I don't know. But there are diet and habits that truly changes the size and the behavior of the fibroids.
Dr. Merhi, our position on these types of things has always been, look, there are things that we know scientifically, and there are things that we don't know. If we don't know something, it doesn't mean that it's wrong. It doesn't mean that it doesn't exist. And I think that as long as something works for the person, that's okay, right? As long as it doesn't do you harm. If you believe a certain diet or a certain exercise regimen or any other adjustment makes your symptoms better, then all the more power. Like, that's not necessarily a bad thing. All I can say is that we don't necessarily see the data or the connection in a way that we can measure and actually prove repeatable results that we can recommend to others. But if someone, and keep in mind, we all have different chemistries, right? We all have different tendencies. I think one of the latest concepts in diet is that, it's not one diet fits all. It depends on the person. It depends on their genetic makeup and what their tendencies are. And so we really don't know all the answers. We know that we have variations from person to person. And so as long as it doesn't do you harm, then, at the end of the day, we absolutely would support it. Me personally as a physician and us, as a group, as a practice at Viva Eve.
So I'm going to ask a question now. So I don't know if do we screen patients? We screen people with pap smear to make sure there's no cancer, right?
Always, yes.
Do you think we should screen people for fibroids? If you're telling me half of the population have fibroids, is it recommended? Why there's no recommendation to do an ultrasound or testing or whatever it is for every single person at a certain age?
It's a great question, Dr. Merhi. I think, one argument against that would be that not everyone is symptomatic. But I think that, it depends on the practice and depends on their style. I'll say that, for us at Viva Eve, honestly, we see the ultrasound as such an integral part of what we do. It's almost like our stethoscope, right? Like, it's an extension of our ability
What's a stethoscope?
Stethoscope is, those old devices that other doctors use.
Yes, okay.
Look, I mean, I think it's a great time in medicine because there's just so much innovation. There's so much technology. Some of it maybe can be still, maybe not as useful. But ultrasound is one of these tools. I think, I know in fertility, in OB/GYN, it just has really revolutionized our ability to look through the body and eliminate the guesswork. I think that the ability to be able to assess the anatomy, look at the way, someone's menstrual cycle is developing, looking at their ovaries, looking at, whether or not someone has fibroids or not, whether they have cysts or not, whether, some of their symptoms that they're feeling, whether it be the heavy bleeding, the painful cycles, the pressure symptoms, the pain with sex, has an anatomical cause, I think takes a lot of guesswork out and is remarkable. think the other tool that we use often, very frequently, especially in assessing fibroids, is MRI. MRI is probably the only thing we'll send our patients out for. And, you know,
so I'm sorry, before we go to the MRI, Dr. Gohar, let's talk a little bit. You mentioned ultrasound. I wanted to ask you about the diagnosis today because we didn't talk about it last time. How do you diagnose fibroid? Tell us step by step about what do I see with the ultrasound? Is it done abdominally, vaginally? Which one is better for you? I do mostly vaginal ultrasound, but which one is best for you to assess the fibroid?
Sure.
And when you do MRI, because I see a lot of people who comes with me to me and they've done MRI, and a lot of people who never did MRI. I'm like, okay, why? Like similar situation. So tell us a little bit about that.
Sure, absolutely, Dr. Merhi. So look, I think those are great questions. I think in our practice, we will always do both a transvaginal and abdominal ultrasounds because I think they both give really good information. You know, ultimately what you're looking at the entire anatomy of the pelvis. You want to look at the, you know, the bladder, you want to look at the cervix, the uterus, the tubes, the ovaries. When we look abdominally, we get a more holistic view. When we look transvaginal, it's a more close view where we can get more specific and see more accurately. Ultrasound, I think, is a terrific tool in general for the pelvis. But when it comes to fibroids, to be honest, it is not, you know, the only tool. And the reason for that is because ultrasound waves, by their nature, are literally ultrasound waves, which is remarkable to me if you think about it. Sound waves that travel through the body. And so fibroids tend to be very dense. And so fibroids can actually create shadows that make it hard for us to get very, very specific and granular. We'll be able to get a very good general idea when it comes to fibroids. And again, ultrasounds are terrific for the uterus, for the tubes, for the ovaries. They're the best modality for these things. But when it comes to fibroids, these shadows can make it so that we will have a good idea. We can say, look, this person has multiple fibroids. They have, you know, fibroids that are approximately this size. Yes, we can see blood flow when we turn on Doppler. But you can't get to the point where you're seeing specific location, specific size, specific number with a great degree of accuracy. You can get a general degree of accuracy, but you're not going to swear by it to a pinpoint level.
Mm-hmm.
And so that's really where MRI comes into play, and I'll get into that in a second. The other tool often used with ultrasound is we'll often, especially for larger fibroids, we'll go all the way up, we'll travel, and we'll look at the kidneys. And the reason why we do this is to really look at what's called the ureters. These are two tubes that come from the kidneys. So if you think of, you know, a typical anatomy, you've got like a silhouette. The kidneys are closer up. They're on the upper abdomen near the back. They're these kidney-shaped structures. If you think of like lima beans. And they essentially are the filters of the body. They're designed to filter one's blood. And from these filters, there are these tubes that travel down all the way through the center of the pelvis and connect into the bladder. This is how we all make urine. And so one of the things we'll find with women who have large fibroids, we'll find impact on these ureters. And so this can really impact the treatment options and how we choose to treat someone. And of course, you know, what the urgency is of treatment. Because of course the ureters, you know, create urine, but if they're not able to, you know, produce that urine and drain into the bladder, that can create back pressure and damage the kidneys if one is not careful. That's one of the rare situations where we will be a lot more, you know, proactive and have to, you know, deal with something on a more urgent basis. Unless, you know, someone has a situation like that or has really heavy bleeding to the point where they're getting blood transfusion. Like I said before, fibroids are rarely emergent and rarely something that one has to treat like an emergent or urgent issue.
Right. Now, the MRI, and I saw this a couple of times, a lot of doctors who do mostly major surgeries, they order MRI to plan the surgery, you know, before ahead of the second map. Do you
Yes.
always do that? And what kind of, is it, do you think it's important? Because look, MRI, I mean, if someone does, it can be very expensive. Okay, I did MRI for my knee, it was tons of money, even though, what I always try to kind of think, not just money, just how to not add extra cost for patients. But tell us where do you order that?
Yeah, these are excellent questions, Dr. Merhi. And you're right, cost is always a factor, something you always have to keep in mind as we do things. And so you want to use the right tools for the right situations. I think, you know, using MRI as a general rule, just because someone has fibroids, I think is probably overkill. You know, some people can do it as a baseline, just so they can have a point of reference. Some patients choose to do that. because they just want to be able to have accurate information, accurate numbers that they can compare to in the future. But most of the time we use MRI for symptomatic fibroids. And I agree with you, it's part of the treatment and planning process. You're basically creating a map of the pelvis with a great degree of accuracy. The key thing with MRI is what you really want is an MRI with contrast. And so just so you know, MRIs use magnets, so there's no radiation to the body at all. But when contrast is injected, it's usually injected through an IV. And what will happen with fibroids in particular, we will find this contrast. We'll literally travel and watch and take pictures of this contrast as it travels through the bloodstream and goes into the fibroids. And so, it depends really on the MRI center. Many centers don't have this protocol. We've developed our own protocols over the years. But what will happen if it's done properly, we're able to get not only the specific location, specific size, specific type of fibroid, we're able to determine with great accuracy the level of activity of the fibroid itself. Right. We can figure out how much enhancement we're seeing through this contrast, which means that these fibroids are lighting up like Christmas lights under the MRI. And when you see the images, it's quite clear what's happening with the fibroid. And so when this fibroid is lighting up like a Christmas light, we know, okay, this is an enhancing fibroid, and this really goes into our treatment options and our treatment planning. We will never treat, for example, a non-enhancing fibroid with an embolization, because what's the point of blocking blood flow to a fibroid if it's already not getting blood flow? Because that's what that would mean.
Well, we're going to talk about embolization. Yeah, no, thank you. We're going to talk about embolization a little bit because this is part of the treatment. Now, if the fibroid is enhancing on MRI, does it mean if you do surgery, it's more likely to bleed?
Yes, that's exactly what it means. If you're doing a myomectomy, for example, or cutting out the fibroid, or if some people choose to even do a hysterectomy sometimes, those procedures are much more likely to bleed and have the issues that come with that if the fibroids are enhancing. If the fibroids are not enhancing, they will not bleed, but more importantly, they're not likely to cause symptoms. And so I think it would beg someone to reconsider the plan in the first place. Is that really the cause of the problem?
Right.
So sometimes patients come to us and their fibroids will already not be enhancing, or they'll have a single fibroid that's not enhancing. And all I'll say to my patients when that happens is, hey, that's a really great thing to happen. That's a good thing. It's not a bad thing. And it's often indicative of the fact that fibroid will not be causing them symptoms.
Right. Well, we're going to talk about fibroid treatment and fertility next session, not today. Today we're going to talk a little bit more about general treatment. So you mentioned something about myomectomy. For those who don't know what myomectomy means, fibroids are called also myoma. Ectomy is when you remove something, so myomectomy is removing fibroids. Tell us a little bit about the types of myomectomies that you do, and when do you decide to go from the belly or from the vagina and stuff like that?
Yeah, terrific question. Yeah, look, myomectomy, as Dr. Merhi said, comes from the word myoma, which again is the Latin name for fibroids. Most of our words in medicine come from Latin, or Greek for that matter. And ultimately, the whole concept of myomectomy is to remove the fibroid tissue. Fibroid tissue, unfortunately, tends to grow back. They're a lot like taking weeds from a garden, and we can get into those treatment options a little bit more at another point. But, it's one of the factors I think that gets lost in translation, especially if the fibroid is enhancing, because basically what that means is that the root of that weed, so to speak, is still pumping and still alive. That's one of the factors we always say to our patients. But putting that aside for a second, just talking about the specific approaches, myomectomies can happen through a few different approaches. One, as Dr. Merhi was suggesting, is when you go from below. If you think of the uterus as like a pear-shaped structure, it's when you go from below vaginally, and then you go inside the cervix, and we use a camera. And if there's a fibroid inside that cavity, within this dead space, I wouldn't even call it dead space. It's actually super valuable real estate. It's where pregnancy would occur. But if you have a fibroid in this area over here, what we call an intracavitary myoma, that's when we will go in vaginally. Because then we can see it under direct visualization with the camera. We will target that fibroid, and with a variety of different tools that we'll use, we will shave off that fibroid to clear the space in the cavity. And that's a very common technique we use quite frequently. There's different situations where that makes sense, but ultimately it comes down to this idea of whether we can see it inside the cavity. If it's in the cavity, that's a very viable approach. Sometimes often people will ask me, well, can you do that for other fibroids? Can you do that if it's within the muscle or within, the outside of the uterus? And the answer is no, unfortunately, never. Because you never want to be cutting through the body of the uterus vaginally. That's only something we would do from above, where we can more safely control bleeding and take whatever necessary precautions and maneuvers we would need to do to keep someone safe and ultimately do the procedure well. The other approaches for us to do a myomectomy would be laparoscopic. That's when we go in through the belly. Laparoscopy is another funny medical term, but basically it's a term that
they should make our terms shorter. They're so long. Hysteroscopy, hysterosalpingogram, laparoscopy. I mean, come on.
I know. It's like these old school docs just want to make it sound confusing.
Anyway, sorry. So you were talking about laparoscopy, yes?
So this involves us making tiny belly incisions on the belly, inflating the belly with a gas, a CO2 mainly. And then with that space that we've created now with this gas, we go in with our chopsticks, if you will, and we operate. So we'll often cut out fibroids this way and repair whatever we have to repair. We'll often do a combination between laparoscopy and abdominal. Abdominal procedure is usually what we call a bikini cut. It's very rarely a vertical incision, but it's usually a bikini cut. And sometimes we'll combine these two methodologies by doing what's called a laparoscopic assisted abdominal myomectomy. That's also a very common technique we will use.
I've never done this in my training ever when I was an OB/GYN.
It's interesting. It's true. It's one of those techniques I think has evolved over the years. I think the logic behind it is you kind of get the best of both worlds. Rather than going in and making incisions without having the ability to see where you're going, you get to go in, remove any adhesions that you may find in your way, confirm that you've got adequate access, and then make your incision. And the goal is to make a mini laparotomy. You usually try to make as small of a bikini cut as you can. And then ultimately you put in retractors. We use various tools for that. And then you start taking out the fibroids, you palpate where they are, and you move them one by one.
So why don't you use we used to do this in residency, believe it or not, like 20 years ago.
The Lexus?
No, the I don't know the name, but you can go inside and shove some of the, I forgot the name. I can't believe it. Morcellator. Thank you.
Morcellators.
Morcellators.
We trained on them a lot, Dr. May, as you know.
I used to do those. It was cool.
I know, we did too. But even then, Dr. Merhi, I think many of us felt like there was something that could potentially be wrong. And I think the time has kind of proven us correct there.
So can you tell us the morcellator, just explain to our audience, please, and how it's done and what it does? All I can tell you, it's just really cool. I liked it a lot.
It is very cool. And it works the vast majority of the time. But unfortunately, they're no longer approved for the vast majority of uses by the FDA and a few other industries. And I think the main reason behind it is, let me first explain what it is. It basically is a device that allows us to go in small spaces and cut up larger tissue so that they essentially get chopped up in small pieces. And then you can take them out of a smaller incision, which sounds great, right? And it is actually remarkably useful, and it historically was useful, unless there's something wrong. So if you guys
something
remember,
wrong, like what? Like why did the FDA said, okay, you can't do the morcellator anymore?
Because if, God forbid, someone had abnormal tissue, if someone had a leiomyosarcoma, and we talked about this before, if you remember in our last session with our audience, we were talking about how rarely there are cancers that mimic fibroids, that look like fibroids but are not really fibroids. They're not very common, but they're common enough where we always have to keep our eyes open for them. Or if someone has abnormal endometrial tissue that was missed on a sampling, or someone didn't do sampling for some reason and it was an incidental finding, and you were morcellating a uterus, now you've just spread that diseased tissue all throughout the pelvis. And so it greatly reduces someone's prognosis and increases the chance that they would, of course, have cancer be spread. So look, it's an unfortunate, discovery. I think it was figured out about 10 years ago, and for that reason, they're a lot less common than it once was. But I think going back to Dr. Merhi's original question, in terms of different approaches for one to do a myomectomy, the last two approaches would be what's called a robotic myomectomy. That's where we use a device, which is essentially a robot. It's got a really cool name. It's called the Da Vinci. We've got some remarkably trained robotic surgeons in our group. They can use these extra articulating arms. And we'll use these tools to essentially magnify and look at the uterus up close. And I think this gives us some advantage. Often what we've been doing the last few years is really combining it now with embolization, which we can talk about a little bit, where you reduce the blood flow before you start using a lot of these extra tools, which can often provide a really great combined approach with a lot of upsides. But essentially it's a laparoscopy, which again is cameras that go into the belly, and you inflate the belly. But we also use these robotic arms that are controlled by the surgeon. So it's as if the surgeon now has 3 extra arms instead of 2 arms, and he's able to operate, or she's able to operate under magnification. So that's really the big advantage there. For a lot of benign disease, we find that robotic surgery isn't quite as advantageous as it is with malignant disease, which thankfully is not the situation with fibroids. But that's just like a side note.
So how does a patient decide whether just want to do regular laparoscopy versus robotic laparoscopy? They both the same holes in the belly, but one is with just regular looking one. Why?
Yeah, look.
By the way, I'm not a big fan of the robot. I'm being honest with you. When I was trained, I'm not saying anything. It's the best thing ever. Just because I think I had ADHD back then. I still have some, but it need patience. You know what I mean? So, but the robot was so cool. But it's too much for me, I think. So that's why. But I think it's great. Patients love it. But tell us, when do patients prefer that?
Yeah, look, when it comes to benign disease, especially, I completely hear you. It's not necessarily that different from laparoscopy. But I'd say that the decision is usually a decision made between the patient and her doctor. It usually comes back to a whole multitude of factors. Location of fibroids, size of the fibroids, ultimately, patient preference as well as a factor. But one of the biggest factors really tends to be weight. If someone is beyond, let's say, a BMI of 40, what we find is that the robot offers some significant advantages.
That's important.
What happens is, as we gain weight, the distance between the anterior abdominal wall and the surface of the body becomes thicker. And this really can impact the ability for us to use laparoscopic surgery effectively. And this really can be neutralized by the use of the robot and can be a significant advantage.
That's huge. That's huge. Wow. So cost effectively, and I'm always thinking, people's money. Which one? I'm assuming the robot costs more, right?
Yeah, I think costs are, like a confusing topic when it comes to healthcare. It's less so, I think, in fertility, because a lot of it, I think, is out of pocket. So I think the cost is more borne by the patient. Whereas, I think in the insurance side of the world, it's a factor, certainly, but it often doesn't necessarily impact the patient as much. So yes, the cost of the robot, I think, is usually more than laparoscopy. Laparoscopy is more than abdominal surgery. And abdominal surgery is more than like a hysteroscopic myomectomy, for example. But I think what we do is, whatever the approach usually is, it's usually a combination of all these different components. And once we figure out what the optimum approach is in terms of like the best upside, the least amount of downside, the shortest recovery time, the one that matches a patient's concerns about risks and benefits, because none of these approaches, whether it be myomectomy, whether it be embolization, whether it be hysterectomy, medication, none of them are perfect. Each one has an advantage and a disadvantage. Ultimately, I think there's a lot of opportunity and a lot of tools that we have today that our ancestors didn't have, and so I think that's really a remarkable advantage. But each one of them has its pros and cons, and some people weigh those benefits and downsides a little bit differently.
So as far as the post-op recovery for the types, the vaginal one, I know you do it and patients can go home the same day.
Exactly.
The ones laparoscopically and robotically, tell us a little bit about those.
Sure. Both for laparoscopy and robotics, we try to get our patients home the same day, but it really depends on the time of the procedure. If we get our surgery done in the morning, which often is not in our control, sometimes that's to do at the hospital, because both of those will always be done in the hospital. Unlike hysteroscopic myomectomy, which will be done either in the office or at the hospital. We will always aim to try to get you home the same day, but that really depends on A, the time of the procedure, and B, the complexity of the procedure and how well someone is doing medically overall, and C, their overall health status and how they're doing prior to the procedure. These things will combine, and so usually I'll say on average it's between a same-day discharge and a one-day layover, so to speak, at the hospital.
So why would sorry, go ahead.
Sorry, go on.
Why would anyone want the C-section cut if there is robot?
You know, it's not always just about whether we want it or don't want it. I think it also comes down to the number of fibroids, the size of the uterus, the size of the fibroids, overall health condition, previous surgeries, whether someone has a lot of scar tissue or not. So these are all factors that will interplay which approach we take. And so also sometimes people will want to have other problems resolved at the same time. Sometimes people will have ovarian cysts, dermoid cysts, issues with their tubes. So there's all sorts of things that we'll often address at the same time if we have another issue. But no, we also as surgeons will try to leave an abdominal approach as a last resort. But there are times where that's the right choice because it's the least risky and has the highest probability of properly treating the problem. Our ability to manipulate with laparoscopy is always going to be less than a laparoscopic abdominal myomectomy, for example, or like a full myomectomy. So we have someone with multiple fibroids, or fibroids are located on the back end of the uterus, a large uterus where the uterus is going all the way up towards the belly button. All these things can interfere with our ability to safely do the procedure with a minimally invasive approach, and we'll then want to use our hands and want to go through an abdominal approach.
Right. Well, we're going to talk about all those approaches and their effect on fertility next time. We're going to talk more about when to do egg freezing compared to this next session, next Thursday. But today, and I'm very excited to talk about non-invasive therapies for fibroids. You know me very well. I don't like invasive things. I like gentle stimulation IVF, natural IVF, everything holistic. Tell us, if I have a fibroid and I went to Viva Eve and I said, Dr. Gohar, I don't want you to cut me or put a hole in my belly. What do you have to, how can you help me? Because I have a lot of patients like this and I am like this.
Yeah, look, I mean, Dr. Merhi, I think I would answer that with probably 3 different paths, depending on the situation, right? Someone has no symptoms or very minor symptoms. I'd say, look, unless there's some major, problem, right? Like it's interfering with fertility based on location, or, it's causing pressure on nearby organs. I would say, look, we can manage this conservatively. We're going to keep an eye on this. We're going to watch this closely. We'll put you on some vitamin D, some magnesium, and we're going to keep an eye on this and see whether or not it bothers you. If it doesn't bother you, and we're one of the lucky people where it doesn't bother you, we leave it be and we don't do anything. But if it does bother the patient, then we're left with 2 non-invasive or what we consider to be minimally invasive options. One would be medication. There's a whole host of different agents that have been recently released in addition to what we've been using traditionally, but they all really do the same thing. They essentially put someone in artificial menopause. They interfere with the hormone production.
Sorry, I don't like those medications. I'm sorry.
You're not alone, Dr. Merhi.
I don't like to put my patients in menopause and give them side effects of hot flashes or anything. Sorry to interrupt you.
I think
this is not something I want.
Yeah, you're not alone. We feel the same way. And more importantly, it's not about what we feel. Our patients often tell us that they don't like that idea. And the ones who do try it really find that it's just really hard. All the symptoms of menopause that one hears about, hot flashes, mood changes, vaginal dryness, skin dryness, hair loss. These things are natural when someone has menopause. It's often a gradual process that takes 3, 4, 5 years. But when you use these medicines, these artificial agents, what happens is this is a sudden shift in a matter of days and weeks. And so most of our patients tell us this is really hard on how they feel, and it really impacts their quality of life. And what's worse, if we were doing this and there's a long-term fix, then maybe you could say, okay, there's a reasonable exchange of risks and benefits here. But what often happens is this really just is a Band-Aid. It's a short-term fix to get someone from point A to point B. So often surgeons will use this. We don't, as a matter of practice, to get someone from point A to point B to make the surgery safer. We find that there's other ways to do so. The last option I'll describe, is one of those tools. But, as a general rule, it's something that we'll use for people who are poor surgical candidates, who are not very healthy, who maybe have other medical issues that need to be addressed first, just to buy time from point A to point B. It's not something that's commonly used outside of those parameters.
Okay, so you said there are two non-invasive things. One is the medication that I don't like. Tell us a little bit about the UFE. Someone is asking. That was my last question. I'm very excited about the UFE. Like, I love the idea. I love it. I tell my patients all the time about it. I know a little bit about it. So why don't you? We're gonna discuss UFE and fertility and who cannot do that next session, next Thursday at 6. But today, tell us in general what UFE is, what does it stand for, when do you do it, how do you do it, exactly, stuff like that.
Yeah, so uterine fiber embolization is really the long name for it. It's often sometimes called uterine artery embolization as well. So sometimes it's abbreviated as UAE or UFE. These are wonderful procedures. I agree, Dr. Merhi. Something we've been known for over the years, and something that I think our patients tell us has been a game changer. And it's something that's not done by OB-GYNs. These are procedures that are done by interventional radiologists. So this is a separate specialty entirely. So their approach is different. And of course, it's something that often isn't well understood in the general community because it's a separate specialty that is often not available to most people. And so what we find is that their approach is, again, different. What they do is they make a small incision the size of a freckle, and they'll go through either the wrist or the groin. Not all interventional radiologists are able to go through the wrist. This is a special type of training.
I'd rather have it in my groin than in my wrist. Just me, but anyway.
Understood. It's fortunate that you don't have fibroids, Dr. Marion. So I think you're a tough patient.
Some people think I have ovaries because I'm very moody. So remains to be determined. But go ahead.
So what these interventional radiologists will do, Dr. Marion, they'll go in through the blood vessels under camera guidance, and they literally will go in and they'll target the blood supply to the fibroids one by one. It's highly effective, highly selective.
So wait, I'm sorry. I want before. I want you to tell me step by step how it's done, because my patients ask me literally about it. So I want to know. You're going to Viva Eve. You want to do UFE. Tell me, what do I do? What's going to happen to me as a patient?
Assuming the workup is complete, assuming that
what is the workup?
A workup usually consists of a pap smear to exclude abnormal cells of the cervix. Imaging.
Okay, we have that a year ago. It's fine.
Imaging.
Okay.
We'll also want to make sure that we've done a thorough physical exam and history to know someone's symptoms and issues, and we've excluded other causes for their problems. And
I have diabetes and I'm morbidly obese. What do you say to me?
It's still okay. Usually the cutoff we find for sedation in an outpatient setting to be about a BMI of 45. But anything below that is absolutely reasonable. And I think it's one of the things that makes uterine fibromization quite an advantage, because people's risks usually don't change a whole lot with their weight as opposed to their belly. And so it's actually ideal for people who have additional risk factors, whether it be diabetes or otherwise, because the healing is so much faster and so much shorter. And then often what we'll do is we'll do a sample of the lining of the uterus. That's often part of the workup as well, to exclude abnormal cells. And we can talk a little bit more about that separately, but I can explain what that entails. It's usually done under sedation as well. It's a very minor procedure, very quick on, very quick out. But at the end of the day, once we determine someone is a good candidate, our process involves you not just sitting down with a GYN or GYN surgeon, but then also sitting down with a uterine fiber embolization doctor, what we call interventional radiologists, who specialize in this procedure among many others. And they will talk to you the way I'm talking to you now, Dr. Merhi, but they'll review the records, they'll pull up the imaging, they'll have a thorough conversation about risks and benefits, and then they will ultimately decide, say, hey, this is what we, decide, the patient will decide, this is the path I want to choose. And we'll say, sure, no problem. Our approach with our treatment options, the way we think about it, Dr. Merhi, these are different tools in our toolbox. We don't get very caught up about which tool it is. I do certain things as a GYN surgeon. Dr. Levin or Dr. Axelrod as an interventional radiologist may do something different. Dr. Gopal or Dr. Sohan may do something different as also GYN surgeons. Our approach is we have all these approaches, we have all these different tools, and the patient ultimately will make the choice that they believe, once they've been properly educated and informed, to choose which tool they believe makes the most sense for them. As long as the patient doesn't ask us for something crazy where, like, we've got to, do some sort of treatment option that's not appropriate, like, removing someone's leg to treat a fibroid, then we really are agnostic. We ultimately will support that patient with whatever they choose. So let's assume they've chosen an embolization, Dr. Merhi. What will often happen is our patients will arrive on their procedure day, and we will do a pre-op. We'll review their medications. We'll review everything after we check their vital signs, and then we will wheel them back to start the procedure. For that day of surgery.
Okay.
Our nursing team is super adept.
So is it called a surgery or a procedure?
We technically consider it to be a procedure, not a surgery. It's a great point, Dr. Merhi, because surgeries usually have a certain connotation and certain understanding behind them. These are just very, very different. If you think about something that's literally the size of a freckle, that's the incision. And so we're often using a needle or a tiny scalpel just to make a tiny little nick on the skin. And while that patient is asleep under camera guidance, we are inserting a very, very thin tube, and we're using the cameras to look at the body as we are doing the procedure. And so the intervention radiologists, Dr. Bilal, Dr. Levin, Dr. Axelrod, Dr. Lean, they will work this catheter through the blood vessel, and they will go all the way through looking with the cameras until they get to the fibroids.
So they go all the way from the arm here, all the way down, and then to the fibroid.
It's a very interesting, Dr. Merhi. I'll digress for a second. Sometimes patients hear this and like, man, that sounds kind of scary. It's remarkable, actually, how unscary it is and how safe of a procedure it is. Like, the risk factors and like the downsides compared to other surgeries are decimal points, fractions compared to surgery. Why? Because you're not cutting the belly. We're not opening things. We're not taking things out. We're not removing organs. We're not, creating scar tissue. We're not even using general anesthesia. This is done under moderate sedation. So if someone feels like they're completely asleep, but it's very quick on, very quick off. There is no tube in their throat or anything. There's no tube.
Oh, it's like it's like an egg retrieval. That's what we do sometimes.
Exactly. Very, very similar. Very similar to what we do with hysteroscopy as well. And so what will happen, Dr. Merhi, is, we'll go in with these, with this visualization, we'll go in and essentially plug off the blood supply to these fibroids one by one. And one common question they'll get is, well, how do they know? How do they know where they are? Can they go in the wrong place? Thankfully, that's not how this works. It's so incredibly mechanical. We're literally seeing this under direct visualization the entire time. I often say to my patients, I use this analogy of the weeds when we're talking about fibroids. When we remove fibroids, through a myomectomy, it's like chopping weeds in the garden, right? You chop up a bunch of weeds, you make a big mess. What usually happens when you take weeds out when you come back? They grow back, right?
Because you still have always.
Yeah, you still have, the soil, you still have oxygen, you still have water. You have all of these nutrients that are kind of feeding these roots that are below the soil that you can't see.
That's a good comparison. I like it.
I think so too. And I think it helps kind of clarify what you do with embolization, because when you talk about embolization, we essentially go below the soil, and you've created a device where you can use camera guidance, and you're targeting the roots one by one under direct guidance. And if you can imagine this invention being around, in real life, what would happen is once you get these roots, the weed would just wilt. It goes away. And that's exactly what happens here. It's not magic. I don't want to make it sound like it's just, all perfect and everything is, so magical. But what happens is, with a great degree of certainty, 90% of the time, our patients report a dramatic improvement in symptoms within 2 to 3 months. And now that's really high odds. 10% of the time, Dr. Merhi, we'll find that we got most of it, but not all of it. And in that situation, we say, look, that's not unexpected. That happens sometimes. If we've gotten most of the fibroids, but not all of it, we'll go in a second time to do a small touch-up and close off any remaining areas. So 90% of our patients are cured after one treatment. 10% of our patients need a second step right after.
And they wake up and they're gone. They walk home.
Absolutely. They go home. We keep them only for about 2 to 3 hours. They go home the same day. There's no hospital stay. And so, look, recovery time also, we always say to our patients, look, there is no procedure without downside. You know, there's pain. There's always, you know, a recovery time for any procedure. So it's not all rainbows and unicorns. But what's different about embolization is just that recovery time is just way shorter. It's much more compressed. So myomectomies have pain, hysterectomies have pain, embolization has pain. But it's just a shorter, more compressed time frame. You spend 2 to 4 hours with us in our surgical center, you go home the same day. Recovery time at home, we tend to be very conservative. We tell our patients to expect 1 week. But for most patients, it's about 4 to 5 days. After a week, you can drive and you can work. And after 2 weeks, you can have sex and go to the gym.
Wow. That's amazing. Again, we're going to talk more about this UFE and fertility treatment next Thursday, you know, with our last session. So, but someone asked, how do you know that you didn't get all the small blood vessels? And 2, how much the fibroids shrink and symptoms wise, and is there a chance they grow back again?
Yes. Excellent questions. I'll answer all 3 of them. How do we know that we got all the fibroids? There's 2 things that we use. One is subjective, or 2 measures, and that the subjective side is how does someone feel, right? That, by the way, is our end all and be all, especially at Viva Eve, but across the board as clinicians. If someone comes to us with 2, 3, 4, 5 symptoms, we want that patient to say to us, look, my life is way better. I feel remarkably better. The duration of my cycle, the amount of flow, the pain with my partner, all these things are way better. That to us leads everything. The objective measure, though, is you were asking before, Dr. Merhi, about MRI. This is one of the areas where MRI is really, really remarkably useful. We do a second MRI. It's a before and after picture at the 3 months.
Wow.
And we compare. And we literally look at these fibroids, Dr. Merhi, that were lighting up like Christmas lights, that now have shrunken and become inactive. And once they're fully inactive, they're dark. They don't light up anymore. They're no longer getting enhanced. And the key thing here, Dr. Merhi, is did we get all the fibroids or did we get most of them? If we got all the fibroid, if a single fibroid is non-enhancing, that thing is not coming back. The chance of that fibroid coming back is less than 2%. It's really unlikely for that fibroid to come back. When you compare that to a myomectomy, current rates for myomectomy are over 50%, sometimes as high as 70% chance of that fibroid growing back. Whereas with this approach, the chances of coming back are only about 2%. So that's one of the major differences. And where people get tripped up is there's a difference between a suboptimal response and a reoccurrence. If someone does an embolization, and this is something we see in the community, and they don't do a follow-up, right? They do it at one of these, like, you know, centers that like does veins or does something else, and they're just kind of doing it on the side. They're not really specialized in this area. They'll often do the UFE, and then, you know, they're not sure how their symptoms are. They'll feel good for a few months, and the problem comes back. What we'll find is it wasn't a complete treatment. And so the body doesn't know that you want to get rid of these fibroids. If there's a little bit of blood supply to the fibroid left, the body will create more collateral blood supply to feed that fibroid over time, and you'll be back where you started after a few months.
So you're saying post-op and follow-up after the UFE, and which is the embolization, is extremely important. Otherwise, you won't get the effect, the maximal effect that you can get at Viva Eve or anywhere. Now, someone is asking, how does it work by shrinking the fibroid? How much shrinking someone can expect, or it doesn't have to shrink, but the symptoms get better?
Yeah. Look, terrific point, Dr. Merhi. And yes, look, I'll answer the question first directly, and I'll give the second layer to what you just brought up. On average, fibroids with this approach will decrease 50% in volume.
That's pretty good.
It's dramatic, right? Over the course of a few months, these fibroids will shrink significantly. The key thing to understand, though, about volume is when you talk about a sphere, let's say someone's got a 10-centimeter fibroid. That 10-centimeter fibroid won't become 5. If it goes from 10 to 7 or 7.5, that's about 50% of the volume. And someone will ask, well, how did the math end up like that? Well, in a volume, if you think about a big sphere, like a basketball, the largest part of that diameter is actually on the outside. So if you peel a few layers off that onion, you've actually made a huge difference. And so people feel that, but when they start talking about centimeters and millimeters, That's really where I'll often stop my patients, and we'll talk about that and say, look, the key objective here isn't for your fibroid to become a certain size. It's not for you to, achieve some sort of, mechanical objective. What you really want is for the fibroids to A, not be active anymore, because when they're not active, they're not going to grow back. And B, most importantly, for them to not make you miserable. If your symptoms are better, your quality of life is better, that trumps everything. And that's ultimately the goal, is to make your life better. So if you feel like you're feeling better, you don't have those issues that brought you in the first place that have really been impacting your quality of life, that's what we consider to be a win. Incidentally, by the way, in case it's useful to our viewers, as many people know, I'm an OB-GYN. I perform a lot of these procedures myself. My own wife, to use as an example, she had the same problem a few years ago. And she ultimately herself chose to do an embolization because we thought it was the right choice for her. It was something that she chose for herself. Her situation was a little bit more nuanced. I think this kind of brings full circle what we were talking about here as a group. And what we were talking about earlier, Dr. Merhi, is she also had a fibroid inside the cavity. And so what we did for her is we did an embolization. And then after the procedure, we went in with a camera and I shaved off the fibroid that was inside her cavity. And so she kind of got the best of both worlds in her specific situation. There's some specific reasons for why we want to do that, but without getting too technical today, we can maybe save that for when we want to get into those kinds of things.
Well, I hope she froze her eggs before you did that.
Yeah, she did, and she's thankfully doing well. And fortunately, she didn't really need to. It was a nice insurance policy to have, but ultimately, she did quite well.
Great. So the UFE seems to be, look, I mean, I've seen a lot of patients. It's actually much more common now done than it used to be. Like I see it. Look, I have a lot of patients with fibroids, a lot, and a lot of them had UFE already. And people think, oh, it's something not done commonly, rare. But I'm glad Viva Eve is here now because I don't like invasive things, honestly. And you mentioned two things that's not invasive: the medication that put patients in menopause, which I hate, and the UFE. So to me, UFE, if I had a fibroid, I would do UFE 100%. I agree with your wife. I think she's a smart woman. I think she should keep you.
I appreciate that, Dr. Ray. I'll let her know that you've given the vote of confidence. One of the interesting things that I often suggest to patients to consider as we think about these different techniques that we use in modern medicine today is it's not unique to UFE. It is an evolution that we're going through in medicine where we want to do things that are less invasive than what we used to do. If you think about like what our parents or grandparents were doing for cardiac disease, I mean, all men mainly after the age of 40, 45, and women often, it can happen at any age, but usually after menopause, have a risk of cardiac disease. And it used to be when people would have, heart attacks, the only way to solve it, the only way to treat them was to crack open their chest, open up their rib cage, and then make an incision in their leg, take vessels out of their leg, cut them up, and put them and basically replace plumbing, and then close the chest again. This is a procedure that became so common that they made a nickname for it. They called it a CABG, right? It stands for coronary arterial bypass graft, right? And it was being done everywhere, right? Cardiac thoracic surgeons were in huge demand, and it was a tremendously needed surgery. Today, it's something that's done for a very small fraction of cardiac patients.
Sure.
Instead, the majority of patients, and this is where there's similarity. They go in with a small incision, size of a freckle, through the wrist or through the groin. The doctors go in under camera guidance, and either they open stuff up or they close things down. And
that's true. It's like the cardiac cath. It's exactly like cardiac cath.
Exactly. And look, I mean, there's many other areas like this. I mean, even trauma surgery is another great example of this. Emergency departments were the same way. Everyone who went to the emergency department had to get an incision from here to here. Now the majority of those procedures are being done by intervention radiologists, and they go in through the blood vessels and they avoid having to go through the belly unless it's really necessary.
We should start doing egg retrieval through the one day.
Well,
seriously, it's amazing. So we should think about it. Look, I like UFE a lot. A lot of people are asking about whether you should freeze eggs before UFE, but we're gonna keep those. The fertility part is gonna be next
So
Thursday. I'm
look, I
very
mean, I'll answer this question, by the way. So, you know, I think it's really a very personal choice. We could talk about it more. I think it's really a very personal choice. I think that there are risks. Those risks are really quite small, but, you know, depending on the person, depending on their